So thank you, Andy. So as Andy said, my name's Sebastian. I'm from the University of York, and I'm a research fellow at the in the Health Economics Equity and Health Economics Equity and Evaluation theme at the NIHR ARC Yorkshire and Humber. And I'm going to be giving a bit of an overview on the principles and origins of economic evaluation in something like 20 minutes. So probably hold on to your hats if you're new to economic evaluation. So just some quick fundamentals. The aim of this presentation is just to give an overview of some of the intuitions and practical applications of economic evaluation, and hopefully to get everybody in the audience thinking and ideally questioning the approaches. I'll try and avoid lists of definitions where possible, leaning more on intuitions, but if I've learned anything over the last couple of years, it's what intuition means to one person is very different to another. A lot of what I cover is rooted in what's conventionally known as the NICE approach to economic evaluation. That's sort of become synonymous, but there's a lot more. And I'm aware that even in that bullet point, I've already had two acronyms that some people might be slightly unaware of. So there are many rabbit holes, as there are with everything around economic evaluation. Some are explored later today by my colleagues, some won't be, and some really are yet to be fully explored. Whenever these rabbit holes pop up, I throw up this image, largely just to defer the point so that you'll have a lot of questions coming up at those moments, and they're very important to have and to keep in your brain. Economic evaluation, it always slightly surprises people, but it's very much still an evolving discipline, and has been since it sort of created in the 60s, 70s, depending on when you want to put the flag in. But a lot of people argue that it's become very sticky as it's become more engaged in policy, trying to update methods and sort of change things has become increasingly difficult. So for anyone that's ever read a health economics evaluation of sort of an RCT, a randomized control trial, or a new pharmaceutical considered by NICE, this might be the sort of statement that you've seen before. The ISA was £22,000 per QALY, which is above the lower bound for what NICE considers cost effective, but below the upper bound. However, when the PSA was considered, there was significant uncertainty, as shown on the CAC. As a result, a VOI analysis was conducted, which indicated a high EVPI, with the EVPPI highlighting the probability of regression being the most significant factor. The health economists in the audience will hopefully be nodding along that that's something that they understand. You could sort of follow along with the logic of that. But it's far from an accessible statement otherwise. Similarly, there's reams of terminology and acronyms that pop up whenever you see economic evaluations reported that rarely come with sort of clear definitions. And in reality, it's very hard to cover all of the definitions that you need to cover in a single paper or a presentation. But while the modern applications of economic evaluation in health can be inaccessible, the fundamentals are really as old as the hills, seeking to address age-old questions of the justifiable expenditure to save life or improve health, while being aware of some of the alternative benefits of that sort of spending. So this is a quote from the Saturday Review from 1871. What is the fair average value of a human life? Would it be right to spend £100 on a head in order to save them, or 1,000 or 1,000,000? The lowest of these sums would obviously be too small. The highest would be too great, if only because the same amount expended in different ways might do infinitely more good. So that's really the key underlying principle of economic evaluation as it stands. How much is it worth to improve life or to save life, and with a sort of mind to how else that money could be spent. But in reality, it's never easy, and that even though this has been in people's considerations for a long time, it's not been resolved. So to be trained in medicine, nursing, or one of the other sharp end disciplines, and then faced with some hard-nosed, cold-blooded economists placing money values on human life and suffering is anathema to many. And my wife would very much agree to that. She's a obs and gynae registrar. So I always think it's a good starting point to anyone new to economic evaluation, or really that has become a bit jaded by it, to go with Alan Williams' quotes, who's one of the founding fathers of modern economic evaluation. So he said, there are far more potentially beneficial healthcare activities than any country can afford. Therefore, some potentially beneficial healthcare activities have to be withheld. If someone says to me that they must have something no matter what it costs, I take them to mean that they must have it no matter what the sacrifices have to be made. And it's always easier to make such statements if the costs or sacrifices are going to be borne by someone else. And I take the objective of cost benefit analysis, so economic evaluation, to be to assist choice, not to make choice, not to justify past choices, nor yet to delay matters. And finally, he very much viewed health economics as the cheerful face of the dismal science. So these quotes paint a simple framework of what economic evaluation should be aiming to do, although not necessarily what it always does. It's to reflect the full implications of a decision, both the observed and unobserved impacts, and doing so to inform and assist policy, not to make the decisions. So why do we even bother? And not just in health, but what's the underlying idea between economic evaluation in any setting? Put simply, it's an assessment of value, but the key is what is value and whose is it? And importantly, what is the value of the other things that we could have done if we didn't do the new thing? So the main principle is that we can't do everything. So how do we measure the value of what we do and what we have to stop to do it? Building on that principle, what can we do and say of benefits to policymakers and stakeholders? So I always try and encourage people, whenever they're doing economic evaluations, keep these general questions in their mind. Who are we talking to and about? So funders, taxpayers, patients, families, or everyone in society? What's their underlying aim of the people in their different contexts? So are they trying to minimize costs, get the most of some outcome, save lives, doing so in a fair way, or to some sort of minimum standard? And how do we measure these aims and the costs of achieving them? So we're talking about measuring long life, healthy life, fairness, economic growth, happiness, well-being, personal wealth, or all of it. And they all have very different implications for how we proceed. So let's go back to intuition and think about the displacement of sweets. So a fundamental truth is more money means more sweets, means more happiness, whether that's for children or grown-ups. If a child had 10p, he'd be able to buy 10p of, say, 1p sweets. So he'd buy this set of sweets. But if he also wanted to buy an ice cream that was 2p, then quite simply, if he put it in his basket, he would have to stop buying 2 of the other things. It's a very simple idea, but one that sort of holds true in economic evaluation of health as well. So let's stick with the idea of sweets just for simplicity for a moment. So pretend that we're back in the days of trips to sweet shops, and I know a lot of people will now be imagining what they would have done with their money back with the last time they went to a sweet shop. I won't judge whether that was recently or not. What sort of things would you consider and why? So it'll be the costs of the best sweets, the enjoyment that you get out of the newest sweet compared to what you'd normally buy, and what could you have done with the money otherwise? More sweets, something else, or the milk that you actually promised to buy. So these are sort of 3 fundamental principles. It's the costs to consider, the benefits of what you're doing, and the opportunity costs. So the benefits of what you would have done otherwise. So how about if we apply this idea to health? Pretend you're an omniscient commissioner of healthcare in a very neat sort of public funded system with no caveats at all, and you're looking to buy healthcare services for your population. So let's think about the 3 things again. The costs to you of, say, the drugs that the pharma company is selling compared to the generic. The amount of additional health benefit it's likely to entail, informed by sort of a randomized control trial or something. And then what else you could have spent the money on. You might have to sell the machine that goes ping, which is a reference that some people get and some people don't. So how do we frame these? So again, let's go back to the costs of the different care options. Consistent with the idea of a single healthcare commissioner, conventionally economic evaluation focuses on the costs of the NHS and personal social services in England and the UK. So a few things to consider. I won't go into detail about how you do all these costing because that would be an entire day's worth of quite dry lectures. But you have to consider the upfront cost of the treatment, so the drug or the surgery costs, and then also the long-term cost implications of the different forms of treatment. So things like increased hospital visits with one drug over another. These are often split into the resource use implications and the unit costs, where the resource use is just how much of something the patient uses. So how many times did they go into hospital, and the unit cost, which is just the cost of each additional bit of care. So one prescription or a GP visit. Conventionally, all other costs are then put to one side, so things like out-of-pocket costs to the patients, other public sectors that bear a cost, or private sectors. But again, this is an enormous rabbit hole that I won't go too deep into. So then the second part, how do we value health, so the benefit of funding healthcare interventions? In specific diseases, you might have clinical outcomes, so things like blood sugars or CD4 counts in HIV, or a hospital might have administrative targets, so readmission levels or delayed transfers. But they aren't strictly health as sort of the public would imagine it. So if you talk to someone about what the NHS is funding, it wouldn't really be a focus around blood sugar counts or reducing readmissions. It's about improving the whole population health. So we had, years ago now, the idea of generic health outcomes were developed, which were outcomes that could be used to try and grapple with this idea of what is health and how do we put a number on it. And many of you will have heard of the EQ5D, which aims to tell us about the quality of life in very general terms. And then it can be combined with the length of that life lived into a quality adjusted life year, so just an adjustment for how long someone's going to live on the quality of it, so a QALY. But again, very big rabbit hole. So I thought I'd quickly give everybody an overview of the most common generic tool that's used to measure health, which is the EQ5D3L. And it's still the one that NICE recommends as of this year. It's been largely unchanged since the 1990s, which is sort of a benefit to it because it's incredibly sort of ingrained in economic evaluation now. The questionnaire has 5-part descriptive system, each with 3 levels, and I'll show you a picture of what it looks like in a second. As a result of these 5 parts with 3 levels, you end up with 243 different health states. And then you can have valuations of country-specific tariffs to generate the QA bit in the QALY, so the quality adjustment. In the UK, these scores give a value between -0.594 and 1, where 0 is the equivalent to death and 1 is the best health imaginable. There's been a recent shift to a new version of the EQ5D, which is the 5 level, but NICE still aren't sort of going with it as their approved method. So this is just a quick show of what the EQ5D3L looks like. So you can see it has these 5 different areas on mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. So I'm just going to quickly run through how you get the numbers out of this. So once you've got this questionnaire, how do you actually get the quality of life score from it? So essentially you're asked to complete the questionnaire with how you feel today in each of these cases. So you could say, I have no problems in walking about, I have some problems washing or dressing myself, I have no problems with performing usual activities, and so on. It could be an extreme pain or discomfort and no anxiety or depression. You then have, again, I won't get into the details, but a tariff machine. So a calculator that you put these numbers into, and it then coughs out based on what your country's scoring looks like, a single quality of life score. So in this case, 0.160. Just to note, the 1 low level, so the extreme pain or discomfort, has a very significant effect on this score, making it much lower than otherwise. So then if you have these quality of life scores, you can then adjust them over time, as I mentioned. So if we've now got the QA bit of the QALY, we need to add the LY bit, so the life years, and bring them together to estimate the QALY. So imagine that we have a trial of 2 treatments, and we've collected EQ5D3L over 3 time points and generated our quality of life scores. So everybody in our intervention starts with a quality of life score of 1, both in the usual care and with the new intervention. Half a year later, the new intervention is still at a quality of life of 1, where usual care, the little plus, has dropped down to a score of 0.5. And then after 1 year, the new intervention is still doing really well. Everybody's at a perfect health quality of life score of 1, whereas usual care is down to 0.2. And then after 1.5 years, for simplicity, we just say that everybody's died. So essentially quality of life is 0 and life years stop accumulating. So you can then join all the dots, and apologies if those lines aren't very clear, but it'll be a bit clearer in a second. And then estimate the areas under those lines to give you the quality adjusted life year. So that for the usual care, it's the brown areas. And for the new intervention, it's everything, it's the brown and the blue areas. So you can then estimate the quality of life years for the usual care, for the new intervention, and then work out the difference between the two of them. So the difference between those two areas. So finally, what do we do if the new treatment's better but more expensive? So this opportunity cost issue. We've covered the costs and we've covered the benefits so far. So this is the final piece of the puzzle. So we need to know how the health gain from the intervention compares to the health lost from what we would have had to stop doing elsewhere, because essentially you're having to pull money from elsewhere in the healthcare system to fund this new, more expensive treatment. So you can see it as two hurdles. So we've covered the first hurdle about whether it's better than the current treatment, so whether it generates more QALYs, but is the extra cost that it might imply worth it? Apologies for the typo on worth it. These are taken from an animation I did years ago, and so it's stuck forever on YouTube with this one small little typo. So how do we actually do that comparison? So first you need to work out how much it costs to gain 1 unit of health with this new intervention. So quite simply, the cost per 1 QALY, essentially. So this then gives you a ratio that compares the additional, so the incremental costs and the effect. And this is what an ISA is. It's an incremental cost effectiveness ratio. So just this cost per QALY gain. So you then compare this ISA to what you would have had to stop doing to afford it. The easiest way to sort of vision this in your head is to think about a bookcase. Now, I really like this idea. So it's this idea that you can line up all of the things that you spend your NHS spending on a bookcase, where the books are ranked by how beneficial they are to the patient. So the health of them is how tall the book is. So ideally, if you had a new intervention, you'd put it, say, somewhere in the middle, and it would push the book at the lowest beneficial book off the end. So the little one right on the far right. But of course, we don't really know the benefits of everything that we do in the healthcare service, and they can't easily be portioned off into these neat little packages. So instead, we have what's called a cost effectiveness threshold, which is an ISA cutoff below which taking money from other current services is worthwhile, and above it, it's not. Unsurprisingly, there's a huge amount of rabbit holes here about how do we value a QALY, how do we apply the thresholds, but the main values to take away from people, for people to take away, are the one that NICE uses, which is this £20,000 to £30,000 QALY, which often you'll see popping up in the media. But then also this Claxton estimate, which was an estimate to actually try and work out what the threshold was in the NHS. So hopefully you're now brimming with questions, whether they're confused questions or what next questions. So things like, what about other outcomes beyond health? Things that aren't included in the EQ5D? What happens when a person's at the end of their life and you can't really talk very well about the life year extension that you'd need to estimate a QALY? What about the impact on carers and loved ones, costs beyond the NHS and PSS budgets? If the effects aren't certain, health inequalities, estimating future effects, whether a QALY is worth the same for everyone. So whether there's this argument for fair innings, so that someone who's already lived a long and healthy life, are QALY benefits to them worth the same? So some of these will be dealt with later by my colleagues, and some are endlessly argued forwards and backwards in the literature, but none of them really have easy answers, but they're all areas that are being developed or have been developed. So really just a couple of takeaways from this, that economic evaluation isn't about valuing health or life, it's about getting the most of each for what the NHS has to spend. The QALY and the EQ5D with it has a lot of limitations, but it is a powerful general approach. And the economic evaluations is to aid decisions, not necessarily to make them. And the fundamentals really are hopefully intuitive, even when the methods can be sort of as thick as pea soup. And I always think this image sort of sums it up very well, that we can't fund everything. That's just a fundamental truth of any setting. So that anything new that has to be funded by the NHS has to necessarily push something else out. So it's just making sure that we've considered the values of those two things and compared them. Thank you very much. I will stop sharing that.
Thanks, Seb. Yeah, really fantastic presentation. You've got some really positive comments in the chat as well, so big thanks for that. So good that you made Jane McDermott's head fall off, which is quite impressive. There's a couple of questions actually. One's gone into the Q&A and one in the chat. So Dawn's asked, I think Chris might have been answering it, but Dawn's asked, Chris, you might want to take it actually. As John said, I assume you can't define quality or ISO without a study or studies that have a control group.
Okay, can I answer that verbally then? I mean, yeah. The process requires you to compare against something. So you do need to have this incremental comparison against a counterfactual treatment option, which may well be usual care. So that's absolutely 100% necessary. How you construct that comparison is a different question, I think. Ideally, we would have large RCTs, which would have all the relevant treatments in there, and we could put that together. But as I think we're going to see later on throughout this, this presentation, the presence of RCTs like this isn't always guaranteed. So we have to be pragmatic in the way that we construct these types of alternative measures. So ideally we would, in practice we can't always, and therefore we need to have some other way of constructing it, but we will always need to be able to compare it to something else in order to get these incremental qualities.
Thanks, Chris. And yeah, there is a Q&A tab at the bottom. I always forget this, so people can put specific questions in the Q&A. I don't mind if they put them in the chat as well. I've got maybe a very quick one, Seb, and then we'll move straight on, actually, just conscious of time. Very quick answer. So John Silcox asked, also worth noting, generic quality of life measures, are they, he says that they may not be sensitive to change as a question. So sensitivity of change of the generic measures.
Yeah, and that's one of the sort of big criticisms of them, and potentially why the shift to the 5L was suggested, to try and make it a bit more sensitive. But there will always be specific issues around specific diseases that need that additional sensitivity. And I think later today we'll be talking about the sensitivity of different outcomes and when you would want to move away from one of these genetic measures.
Yeah. Marvellous. Big thanks, Seb. There's another question, but we might take that forward to the panel discussion. Actually, that might be something to take